más que nada quería hacer una breve introducción para, bueno, creo que el doctor Firas no necesita presentación. Yo lo que quería más que nada era agradecer a todo el mundo. La verdad estamos pasando por una situación bastante compleja. Compleja creo que no solamente personalmente, alguno lo está viviendo de una forma un poco más dramática que otras personas. Algunos le están restando importancia, la verdad que están subestimando el tema, como lo vemos todos los días en la televisión. Pero creo que esto es algo que está afectando a todo el mundo por igual. Y creo que en este contexto debemos cuidarnos entre todos, debemos prestar atención a lo que hacemos, debemos tomar las medidas necesarias. Creo que es fácil en los dos extremos. Creo que es fácil, por un lado, subestimar las cosas, como por el otro lado, ir hacia el otro extremo, que nos mete también en un terreno de miedo. Y el problema con el miedo es que paraliza. Todo lo que se estuvo hablando hasta ahora, aparte de lo que presentó Antonio, tenía que ver con cómo luchar contra ese miedo. Me refiero a lo que hablaba Antonio, que lo hablaba de una perspectiva de términos de comunicación. Luego las charlas de Sebastián y Juan Pablo desde la parte técnica sobre teoría y demás, y con Fernanda desde lo clínico. Lo que intentamos hacer desde Tecnoimagen es romper un poco esa ansiedad y sacarnos de la zona del miedo. Como es muy fácil meternos, como comentaba antes, en una zona de confort, y es difícil salir de esa zona de confort. Es muy fácil meternos en una zona de miedo y luego salir de esa zona de miedo. Es muy difícil salir de la zona de miedo. Y lo que buscamos nosotros con estos webinars es básicamente trabajar en lo que es la educación. No solamente en la educación, sino también para prepararnos para salir entre todos de esta situación. Creo que cuantas más herramientas nosotros podamos juntar en este periodo, con más fuerza, con más energía positiva vamos a poder salir, y es algo que eso sí tenemos que transmitir. No subestimar el tema, no quitarle la importancia que tiene, pero sí transmitir energía positiva. Y esto va a pasar, lo que tenemos que hacer en el medio es cuidarnos entre todos, cuidar a las personas más expuestas, y lo que sí es no quedarnos en esta zona del miedo, ¿no? Porque esto, si estamos en esa zona, nos va a paralizar y no vamos a poder prepararnos para la salida. Y creo que hoy más que nunca tenemos que estar preparados para cuando salgamos de nuevo, cuando este tsunami, esta tormenta pase, salir con todas las fuerzas como para poder recuperarnos. Recuperarnos nosotros no solamente implica que cada uno personalmente se va a recuperar, sino que va a ayudar al resto a recuperarse también. Yo creo que, bueno, fueron entrando bastantes personas ya. No hay mucho más para decir, no quiero quitarle tiempo a Firas. Firas es el experto. La metodología vamos a hacer es Firas va a estar hablando, como siempre hacemos en todas nuestras charlas y en nuestros eventos, de una perspectiva totalmente clínica. Lo que buscamos es que cada uno de los asistentes se lleve herramientas para su práctica diaria, tome conceptos, tome tips, más allá de la tecnología que tengan, y que obviamente puedan aprovechar de todo el conocimiento del doctor Firas sobre su experiencia, su trayectoria. Él escribió un montón de papers también. Por lo tanto, Firas va a estar hablando desde una perspectiva totalmente clínica, todo lo que es el mundo de los láser y aplicado a cicatrices. Y pueden ir haciendo preguntas en el chat, idealmente en inglés. No soy experto en inglés, pero lo que voy a estar tomando, si no es en inglés, yo tomo las preguntas y luego se las traduzco a Firas, y todas las preguntas van a ser respondidas al final de la presentación, pero pueden hacerlas en cualquier momento. Creo que nada más, así que los voy a dejar ahora directamente con el señor Firas. Firas, all the audience is yours. Salutation already done.
Thank you, Pablo, but this was a long introduction. I wasn't sure what you said. Okay,
No,
shall we start?
it's okay. I was just talking about the current situation, how to avoid the fear, how to be positive. That.
Okay, so thank you very much. I will start, and as agreed, you will write the questions and then discuss with me later.
Okay.
First of all, can you check with everyone that everyone can hear me and can see me? Can we check that, please?
Yes, you don't worry, because if there is someone that is not hearing you or seeing you, they are going to put it in the chat. So don't worry.
Yeah, I mean, I am not going to read the chat now. I will minimize the chat. Yeah, someone is saying yes, very well, but I'm not going to open the chat. I will leave the chat to you. Okay, so I will start. Thank you very much, Pablo. Buenos dias. Good morning, everyone, because most of the audience where you are is still morning. It is afternoon here in London. And I would like to thank Niaimi and Pablo for giving me the chance and the opportunity to give you this webinar. I think times are changing, and this is a unique opportunity for all of us to exchange and share knowledge through the use of technology and a webinar. So I would like to spend the next hour, or maybe a bit longer, talking about lasers and scars. And what I would like to do is just try and make it practical, really. Try and just run through how I approach scars using lasers, share with you some key important clinical papers and publications, and really just to give you an idea about next time when you see scars and you would want to treat them with lasers, at least how to approach that matter well. There is a lot of chats, but if you can just slow down on the chats, please, and then we'll leave that to the questions at the end. Okay, so just a little warm up and a little bit of background. We all know that scars are basically abnormal tissue, and there's either excessive fibrous tissue or loss of it with atrophic scars. The problem with scars is that they have an inferior cosmetic appearance, poor tissue quality. The one thing that I have learned a lot from dealing with patients with scars is, regardless of the objective assessment of scars, they tend to have a profound psychological impact on its sufferers. So the first thing I would like to share with you from my experience is that any improvements, any objective improvements in the scars will mean a lot to the patient. This is the one branch of dermatology or plastic surgery where we don't necessarily want to quantify the improvements and the objective improvement that we see in percentages. Like, for example, if we are looking at treatment for psoriasis and we want a reduction of a minimum of 50%. What I found from my experience with patients suffering from scars, that even if you give them 20% improvements in the scars, that actually will mean a lot to them, to their psychological well-being and to their quality of life. So just take that into consideration, that patients with scars will be very appreciative of any improvement that you could offer them. And then, of course, there are different types of scars. The reason why it's important to understand that there are different types of scars is because the approach and the treatment for these scars will be different. So we have the atrophic scars. They can be flat or depressed atrophic scar, where there's predominantly loss of tissue. There's predominantly loss of collagen tissue. There is also the hypertrophic scars, keloid scars, surgical scars, and burn scars. And burn scars in particular are quite challenging and difficult because they can be very heterogeneous. So they can have hypertrophic components, they can have a vascular component, they can have a hyperpigmented component, they can also have symptoms of itching, or there might be some restriction. So it's important to first appreciate there are different types of scars. And when we are going to approach treatment, it's important that we understand what scar we are dealing with, because the approach in terms of treatment is going to be different. What you see at the bottom of the slide is important, because what we're seeing there is the wound healing process. So as we know, after any injury, there's a wound healing process that takes place, and ultimately, as a result of that wound healing, we are going to get, the repair. So usually what happens, if there's an abnormal wound healing, then we are going to get this abnormal scar. So the wound healing goes in 3 key phases. That's the inflammatory phase, that takes about a week. The proliferative phase, which is the important phase, that starts from the first week up to around 2 to 3 months, really, but it's predominantly the first month, really. And then we have this remodeling delayed phase that can take 2 to 3 years sometimes, okay? And this is why when we're doing a procedure or even just a surgical excision, we will say the scar is going to look better in a year's time. And the reason for that is because you have this ongoing delayed remodeling phase. Now, I want to just concentrate on the middle part, which is the proliferative phase, because the proliferative phase is a very important part, a very important phase in early wound healing, because it will determine what type of outcome you are going to get. Proliferative phase is proliferation. So it's not just proliferation of fibroblasts or proliferation of keratinocytes for reepithelialization, but it's also proliferation of blood vessels. So there is an angiogenic phase here, and this is why early on the scars are going to appear red. So now you understand that when we are going to intervene early on in terms of treatment, so let's say 2 to 3 weeks after surgery, which is early intervention, we are predominantly modulating the proliferative phase. And I will show you later in this webinar how modulating and interfering early on in that proliferative phase can give us better outcome. So just remember this. Remember the reason why treatments with lasers early on, at an early onset of scarring, gives us better results is because we are intervening with the proliferative phase. And proliferative phase is not just keratinocytes and fibroblasts, but more importantly, blood vessels and angiogenesis. And now you wouldn't be able to make this link, for example, with the use of some of the vascular lasers, such as the pulse dye laser. We will talk a little bit more in depth about these. So now, I'm a dermatologist, but even my colleagues, plastic surgeons, will be familiar with most of these treatments that I have listed here. There are many treatment options for scars. So we have topical treatments, silicone gels or sheets, steroid injections, triamcinolone injections that come in different concentrations are also very popular treatments. And then we have some other treatments such as botulinum toxin, fillers if there is a depressed atrophic scar with loss of volume, and of course surgery. Surgical revision of a scar is possible. But I'm going to talk here during this webinar about the role of lasers in the management of scars. The take-home message is very straightforward and is very simple. There's definitely a role for lasers in the management of scars. It definitely does work. That's the take-home message, okay? So if there's anything that you would need to learn and take away from this webinar, is that there is a definitive role for lasers in the management of scars. And they can improve on a number of objective parameters. Color, if you have a red or a brown scar, we can decrease that with the lasers. Improvement of the texture, the surface, how the scar feels. Pliability is how soft or hard the scar is. So a very hard scar, when we are treating, for example, with series of fractional lasers, we can get improvements in the pliability. The scar is going to appear softer. As you can see, if you have a thick scar, whether you would combine that or not with topical steroids or injectable steroids, but by using the lasers, not only do we soften the scar, but we decrease the thickness as well. And of course, symptoms, for example, itching, pruritus post-burns is a very troublesome symptom in some patients with burn scars. And we can decrease the symptom of pruritus or pain by using the pulse dye laser, and I will show you some clinical papers there. But most importantly is this, and this is why I have it written in capital letters. Lasers have shown to change the histology of the scars. So it is not just the appearance. It's not just something that looks like a scar is going to be looking less like a scar once you use the lasers. No, something is actually happening into the scar itself. The matrix, the buildup of the scar is going to change. The lasers are going to change the abnormal tissue of the scar into a little bit more of a normal tissue looking. So it is changing at molecular level the behavior of the scar. And that is very interesting, and that is very important too. So I just want you to be familiar with this concept, is that the lasers are not just acting on the appearance of the scar, but it's changing the histology and the molecular behavior of the scars. And you know, we have come a long way when it comes to the treatment of scars using a laser. So this was the first ever paper published on the use of a laser in the management of scars. This was in 1995 in the Lancet, so 25 years ago, when Tina Ulster from Washington presented about the use of the pulse dye laser. At that time, the pulse dye laser had the 585. It's now the 595 that we use in a keloid sternotomy scar. This was the first ever reports in the medical literature about the use of lasers in scars. But now it's a completely different game. We now have hundreds, literally hundreds of clinical papers regarding the management of scars using lasers. We even have algorithms. We even have consensus papers. So we have come a long way as dermatologists, as plastic surgeons. We have come a long way in the management of scars using lasers over the years. So this is going to be the outline of my webinar. The key three things that I would like to discuss. First of all, we're going to be discussing the mechanism of action. So in simple terms, how do they work? Why, when you're using a fractional laser on a scar, why is the scar getting better? So the mechanism of action. And I think as doctors, it's important that we understand how things work before we apply them to our patients. The next is, how can we use these lasers? So when, in terms of intervention, what type of laser are we going to use for which scar? And then, of course, it's difficult to give settings without looking at the individual scars, and that comes from experience, but to try and give you an idea about how to approach the settings when it comes to the scars. And we'll then finally run some clinical examples and some of my cases to just give you an idea about how I approach these cases. So we'll start first with the first point, which is the mechanism of action, which is how do actually lasers work in scars. Okay, so the two key components in terms of lasers that work with scars are the vascular lasers and the fractional technology. So these are the two main technologies, main laser or light-based technologies that are going to work in scars. So when I'm talking about vascular, that is predominantly the pulse dye laser, but of course the Nd:YAG 1064 or the KTP 532 also belong to the vascular lasers. When I'm talking about the fractional technology, I am not just saying fractional CO2 or fractional erbium. I'm referring to all the fractional technology. So in simple terms, I'm including here the non-ablative fractional technology, which has different wavelengths, as well as the ablative fractional technology. I'm also here relating to the fractional technology of the picosecond technology. So all the fractional technologies, be it pico, be it ablative or non-ablative, plus the vascular lasers, what they have shown is that they have the tendency to shift the abnormal scar tissue towards normal tissue architecture. So if on one end you have a scar tissue, and on the other extreme end you have completely normal tissue, each time you're using a vascular or a fractional laser into this abnormal tissue, which is the scar, you're moving it closer towards normal tissue. So it is scar rehabilitation, scar resuscitation. You're blowing in life into the scar. You're remodeling the abnormal architecture of the scar to try and make it look a little bit more like normal. This is what we're doing when we are applying the vascular or the fractional technology. So now first, I would like to talk about the vascular lasers. If you go to any conference, or if you would hear someone talk about the vascular lasers, you will see this simplistic way of how the vascular lasers would work. And I have put there on top the main wavelengths that are used. Essentially, the pulse dye laser is the one that has most of the evidence behind it, but nevertheless, the Nd:YAG 1064 and the KTP 532 are also vascular lasers. And then the common conception, the common thinking is that we're dealing with the vessels, and as a result of dealing with the vessels, we're getting a reduction in the redness and improvement in the scars. But there is more to it. And the reason I put modulation of angiogenesis in the proliferative phase is, once again, just to remind you that the wound healing goes through three phases. The inflammatory phase for the first few days, then it's the proliferative phase, which is the important phase, and then finally the remodeling phase. When we are using the pulse dye laser, the vascular laser, for example, very early in scar management, we are modulating the angiogenic phase. So we are slowing down that abnormal angiogenesis, and that will steer the wound healing into more normal wound healing with less obvious scarring. But there is more to the vascular lasers and how they work than just attacking the vessels. Here, I would like to show you there are a number of papers in the literature, but I have just picked three key important papers that anyone who's using a vascular laser in scars should be familiar with. What these papers are showing is that when we are using the pulse dye laser in scars, a number of biochemical changes occur in the scar. First of all, we are suppressing TGF-beta1. And remember, wound healing with TGF-beta1 is going to give us a bad outcome. The number one is likely to give us a bad outcome. So whether that's TGF-beta1 that initially gives us a lot of collagen type 1, which is more fibrotic, but anything with a number 3 is a more favorable one, because when we have TGF-beta3, we are going to have better wound healing. So what happens with abnormal scarring is that we get too much of TGF-beta1 and too much of collagen type 1 and less of TGF-beta3. So what we want to do is we want to actually get a favorable wound healing response and get less TGF-beta1 and more of TGF-beta3. So these are some of the papers that have published that is showing exactly how the pulse dye laser, in this case it's clearly the pulse dye laser, because this is where most of the evidence stands for in the management of scars at this level when it comes to the vascular lasers, is that the pulse dye laser suppresses TGF-beta1, which we don't want too much of TGF-beta1. It suppresses also a horrible growth factor called CTGF. Now, CTGF is a growth factor that is elevated in hypertrophic scars and keloids, but is absent, is not found in normal tissue. So it suppresses CTGF, that is going to give us hypertrophic scars and keloids. It suppresses TGF beta 1, and it increases collagenase type 3. And collagenase type 3 is the one that we want to break down abnormal tissue. So this is important because the pulse dye laser is not just modulating the abnormal vessels. It's not just modulating the angiogenesis, but it's doing other things in the scar, which is suppressing TGF beta 1, suppressing CTGF, and increasing collagenase type 3. And these changes are important because when you're using the pulse dye laser in scars, you're suppressing TGF beta 1, you're suppressing CTGF, you're increasing also P53, which is pro-apoptotic, you're upregulating collagenase type 3, which is matrix metalloproteinase type 13, and all of these changes lead to favorable collagen remodeling. So next time there is a scar and you're treating it with a pulse dye laser, the complete answer is you're not just targeting vessels. You're modulating the TGF beta, modulating the matrix metalloproteinases, suppressing CTGF, and increasing P53. And all of that is giving us favorable collagen remodeling. Okay. Now, there is also a difference in how you use the pulse dye laser in terms of parameters. Now, remember, when I told you, when we are using the lasers early on, so week 2 or week 3 post-surgery, we don't have established thick hypertrophic or keloid scars. We don't. What we want to do then is modulate the angiogenesis. So we don't need to use aggressive settings there, okay? So we use non-purpuric conservative settings. And this was an excellent paper that looked at purpura versus no purpura in surgical scars early on. And then in fresh surgical scars, so that is, let's say, 2 to 3 weeks after surgery, you don't need to be aggressive, and you don't need to get purpura, okay? Because we are not at that stage breaking down abnormal collagen tissue. All we are doing is modulating the angiogenesis, increasing the P53. So it's biomodulation almost. But this is different when we are treating a thick hypertrophic or a keloid scar. Now, I have treated many, and I can tell you that it is going to be fluence dependent. Let me share with you one finding from an excellent study that was published a few years ago in Lasers in Surgery and Medicine. This was in established hypertrophic and keloid scars. This was with a pulse dye laser using a 7 millimeter spot. And what you see is that the pulse duration was the short pulse duration, 1.5. And then they used low fluence, which is 6 joules, moderate fluence, 8 joules, and high fluence, 10 joules. And they were looking at CTGF. And what you can see is you see that at 10 joules per 1.5 milliseconds, and those of you who are familiar with this pulse dye laser will know that the combination of these parameters is going to give you some purpura, as you get more suppression of CTGF compared to 6 joules. So when we are talking about established thick hypertrophic and keloid scars, the suppression of CTGF factor was proportionate to the fluence. In other words, when you're treating thick scars, I like to see a little bit of purpura, okay? Because that's going to give me better results. But when it's a flat scar or it's a pulse dye laser treatment post-surgery early on to prevent abnormal scarring, I don't need to get purpura. So there is a difference in how we use the settings depending on the type of scar. So just remember, the reason when in thick established scars, we want to get a little bit of purpura, not intense, just a little light purpura, is not just because we are destroying abnormal vessels. is because when we are using that, we're giving sufficient fluence that is also going to suppress this horrible factor, the CTGF factor. So it is to suppress these abnormal growth factors. So this is a very recent paper. This paper I can send to Pablo, and then Pablo can send it to all of you. It's, you can get it free of charge. It's a fantastic paper, and I'm one of the co-authors on it. This is from the International SCAR Consensus Group. Some of the authors there you might be familiar with. And we looked at all the literature. We had several meetings, and we have outlined for you exactly what I'm talking about. How do lasers work, and which parameters and which intervals. So it's a great paper for you to read. I will email this to Pablo, and then Pablo can email it to all of you. But I just want to pick up one paragraph that we discussed about vascular lasers. And when it came to vascular lasers, the pulse dye laser was the first choice of more than 80% of the panel. So we know that when it comes to the use of vascular lasers, and once again, when we talk about vascular laser, we're not just talking about reduction of redness. That's a very simplistic approach. We're talking about suppression of TGF-beta1 and CTGF, and upregulation of collagenase type 3 and P53. The pulse dye laser had most of the evidence. This is why, in comparison to the KTP or the long pulse Nd:YAG, when it comes to these effects on scar tissue, the pulse dye laser is the one that has the best level of evidence. Okay, so that was vascular lasers. Now I want to move on to the fractional lasers. Now, as you know, fractional lasers, it's basically fractionating the beam of light. So you're getting these columns of light in a fractional method, and they are either going to remove tissue, so ablate tissue, which will be called ablative, such as the erbium YAG or the CO2, or non-ablative, which will just heat up the tissue, but there is no ablation or removal of tissue. And then the key parameters are important. So the fluence, in fractional lasers, the fluence will dictate depth. So higher fluence will give you a deeper penetration. So if your target is deep, then you're going to be using a high fluence. And also density, the coverage area. So the higher the density, the more impact on the tissue, but also potentially longer downtime or higher risk of complications. And the relationship between the fluence and density is inverse. So if we are going to, for example, if we have a very thick scar and we need to go very, very deep, we are going to use a high fluence because we need to go deep, and then we are going to reduce on the density. But if it's a more superficial scar, then we don't need to use very high fluence because depth is not particularly an issue here. Then we can afford to use a higher density. So just remember, with the fractional lasers, the relationship between the fluence and the density is inverse. Okay, so if you increase the fluence, you have to decrease the density. And you would increase the fluence in fractional ablative and non-ablative lasers when you want to get deeper. Of course, that depends also on the type of laser that you're using and the histology studies with that laser that dictated or calculated the depth. So when it comes to non-ablative fractional lasers, non-ablative fractional lasers will have wavelengths between 1200 and to 2000 nanometer. Once again, between 1200 nanometer to 2000 nanometer. Because the non-ablative fractional lasers are going to use water as their chromophore. They're going to heat up the water, but they are not going to heat up to over 100 degrees to get ablation or vaporization, because otherwise it will be an ablative laser. But they were going to heat it up to 65, 70 degrees, so you get the coagulation, the shrinkage, and the wound healing. So typically, these are the wavelengths that we are using. Now, the non-ablative fractional lasers are important in scar management, but they are particularly good for the flattened atrophic scars. They are inferior to the ablative fractional lasers, so the AFR, ablative fractional lasers, in thick scars, because in thicker scars, the ablative lasers are superior. But when it comes to the flat scars, the fractional non-ablatives are a very good option. There are also a number of studies regarding the efficacy of the non-ablative fractional laser and improvements also in color. So these are some examples of these flat scars that you can treat, and of course you'll need a number of treatments with the fractional non-ablative lasers to get improvement. But it's a very good choice for many of our scars, be it surgical scars, traumatic scars, or even prevention of scars early on. But it's really the ablative fractional laser that's the key game changer when it comes to the management of most of the scars, in particular the hypertrophic, the thick scars, or the burn scars. This is why in most of the plastic surgery burns departments, they use the fractional ablative laser, the CO2. And that is because depth also matters. But also, in addition to that, vaporization, so ablation and removal of abnormal tissue, is also giving us that microtension relief, that instant relief in that tension. The scar somewhat initially just feels a little softer. Of course, you will require a number of sessions. And this is just an example of a histology of the recreation of these Rita ridges. This was from one of the studies from Jill Weibel, of the recreation of the Rita ridges following the use of ablative fractional lasers. So what you see is that the abnormal tissue is starting to look a little bit more like normal tissue. So it's almost this, once again, rehabilitation or normalization of the abnormal structure, abnormal histology of the scars by using the fractional technology. Okay, so once again, let's just talk about why do fractional lasers work so well in scars? To answer that question, okay, we need to get back to embryonic or fetal wound healing. So what happens is you will never see a baby born with scars. You don't. Even though there might be intrauterine trauma, the babies will heal scarlessly. So they will heal with no scarring. The wound healing in a fetus is scarless, which is different from the adult wound healing that gives us the scar. And this is an excellent paper, actually from my university, the University of Manchester. If you want to read it, on the scar free healing and the embryonic mechanisms. In simple terms, fetal wound healing is very rich in TGF-beta3, very rich, with very high levels of TGF-beta3. And once again, just to remind you, when it comes to wound healing, anything with 1 is not good, and anything with 3 is good. So when you have wound healing with high levels of TGF-beta3, you are going to get a very good outcome, and almost a perfect scar or scarless. When you are having TGF-beta1, which is the adult wound healing, that's when we're going to get this phase of collagen type 1 that eventually then changes into collagen type 3. But what happens with, for example, prolonged inflammation or prolonged tension, that conversion of TGF-beta1 to collagen type 1 and eventually from collagen type 1 to collagen type 3 doesn't take place, or is slowed down, or is delayed. And this is why you tend to get more of the collagen type 1, which is the fibrotic scars. So we want to have, ideally, when it comes to scarring and wound healing, we want to have a lot of TGF-beta3 with very little TGF-beta1. And that is exactly what the fractional lasers are doing. The fractional lasers do exactly that. Once again, there are many, many papers published in the literature on this, but I have just outlined few. And that is, when you have scars and you're treating them with the fractional technology, because of the generation of specific proteins called the heat shock proteins, and in particular, heat shock proteins 70 and 47. So the initiation of these proteins, the heat shock proteins 47 and 70, because of the fractional lasers, is going to kickstart a wound healing process that's going to increase TGF-beta 3 and decrease TGF-beta 1. That's exactly what we want. Once again, anything with 1 is bad, and we are suppressing that. And anything with 3 is good, and we are increasing that. And that leads to collagen switching, because when we have TGF-beta 3, we're then promoting collagen type 3. So what happens when we use the fractional ablative lasers is, because of the increase in the specific heat shock protein profile, we are then increasing TGF-beta 3 and suppressing TGF-beta 1, and switching the collagen type 1 to collagen type 3, which is called the collagen switching. So what happens when we use a fractional? So almost all of these studies were performed with a fractional CO2 laser. As we are decreasing TGF-beta 1, that's great, because we don't want too much of TGF-beta 1 in wound healing. We are increasing TGF-beta 3. We are switching collagen type 1 to 3, so it's called collagen switching. Collagen realignment, so it's becoming more cellular. So the histology from a scar before and post fractional CO2 is showing that post fractional CO2, there is more cellularity, and the collagen fibers are better aligned together. So the alignment is better with more cellularity, increased extracellular matrix, and all of that leads to normalization of scar tissue. So once again, when we are using the fractional technology in scars, we are rehabilitating the scar, we are resuscitating the scar, we are normalizing it from very abnormal tissue into normal tissue. And how does that happen? That happens through modulation of TGF-beta 1 ratio to 3 and the collagen type 1 to 3, increased extracellular matrix, and collagen realignment. So it's not as simple as just breaking down the abnormal scar tissue. And this is one of the key differences between the fractional technology and, for example, a process like microneedling. Because the studies have shown that the microneedling do not initiate the heat shock proteins 47 and 70. You do not get heat shock protein activation with microneedling. As a result, you don't get this wound healing cascade of increasing TGF-beta 3 at the expense of TGF-beta 1. So there is a lot at biochemical level how the vascular and the fractional lasers work in terms of scar remodeling. So just remember, scar remodeling, scar rehabilitation through a change in the biochemical pathways and the molecular behavior of the scar. That's how I would say it, and that's how I would explain it. So once again, the changes in the heat shock proteins and the elevation of TGF-beta 3 at the expense of TGF-beta 1 is going to give us favorable remodeling. This is why the scar tissue is going to look better. So in other words, the controlled wounding of the skin from the fractional technology is giving us a favorable tissue healing response in scars. So this is an important slide. Okay, this is an important slide. So now, as I said, my talk was outlined first in mechanism, how do lasers work, and I explained that. And now, which laser and how to use them. Okay, so basically, the ablative fractional laser can be used in any scar, but then your parameters are going to be different. So you can use that in prevention, which is post-surgery. If you have, for example, a surgical wound and you want to give a better scar, you can use a fractional ablative laser, of course. Your settings are going to depend on the anatomic location, the skin type, the skin thickness, okay? If it's a flat scar, of course you can use it. Hypertrophic thick scar, of course you can use the ablative fractional laser. your parameters are going to be high fluence, low density there. On a flat scar, lower fluence and higher density. So the ablative fractional laser can be used in any scar. Non-ablative fractional laser, again, perfect to use for prevention post-surgery, perfect to use for the flat scars, the atrophic scars with volume loss, plus, for example, a volumizer or not. But I wouldn't use them as first line for the very thick hypertrophic or keloid scars. For those, I would prefer the ablative fractional laser. The pulse dye laser, again, as I showed you, when you use it early on, so what I mean with prevention, I mean post-surgery. So you do a surgical excision, surgical removal of a lesion, and you want a better scar. After 2, 3, 4 weeks, you are going to intervene with the pulse dye laser, so that is intervention. And as I showed you and told you, that when you're using it at that early stage, you're modulating the angiogenesis. So the pulse dye laser can work equally well compared to the non-ablative fractional laser for the prevention. If there is a redness component, and that is what you want to target, a red scar, and you just want it less red, again, you can use the pulse dye laser, or you can use, as I said, as I'm showing below that, the KTP or the Nd:YAG. For the thick scars, you can use the pulse dye laser, but as I showed you, your parameters are going to be different. For these thick scars, the suppression of this abnormal growth factor, the CTGF, was dependent on the fluids. So there I would seek a bit of purple. And then for a mature scar, so a mature scar is those scars that have gone through the remodeling phase and no longer going to change. So a scar, for example, from 10 years ago, that could be a cesarean section scar from 20 years ago. That's a mature scar. You can use a fractional laser, of course. You can add in the pulse dye laser if there is redness. Okay. So this slide is important. What you can see is that the fractional laser can work on pretty much any scar. Okay, pretty much on any scar. We're talking about the ablative and the non-ablative. The pulse dye laser, it's perfect for early prevention, for red scars, and also for these thick scars when there is redness present. This is just one study by our Korean colleagues. Is a very good study, and this was a split scar study. This was post-thyroidectomy on the neck, so thyroid gland removal and then post-thyroidectomy scar. Early on, they split the scar into one half with the pulse dye laser and the other half with the non-ablative fractional laser for scar prevention. Once again, so that is early intervention, okay, with the lasers to give us a better scar. And there was not much difference. Both of them improved the outcome. But the pulse dye laser was more cost effective. There's no need for anesthesia, less pain, and it's easy to use. So this really, the take home message is that when it comes to early intervention, okay, the pulse dye laser can also work as well as the non-ablative fractional laser or the ablative fractional laser. This is one of the studies that looked at the difference between pulse dye laser and fractional CO2. Both of them improved on the scars, but when it comes to the thickness or the contouring, the CO2 was superior. We know this. But when it comes to really the vascularity and the redness, the pulse dye laser was superior. So in reality, in practice, most of the time we end up combining. We combine these two lasers because they're doing two different things. They're working synergistically with each other. And this is one study that is a relatively recent study. This looked at pulse dye laser alone versus pulse dye laser plus fractional CO2. And this was in these red hypertrophic scars. The combination was better. So if you have a thick red scar, you can use the pulse dye laser alone, or you can use the pulse dye laser in combination with the fractional CO2. And when you use it in combination, you get better results. And that's also my experience. This is another study that was, again, relatively recently published in Lasers and Medical Science on the combination of the pulse dye laser and the fractional CO2 in the same session. And that's what I tend to do a lot, in the same session. So that's using the pulse dye laser first and immediately afterwards using the fractional CO2. There are different ways of doing it. Some colleagues would like to just start with the pulse dye laser first, few sessions, get improvement, then do the fractional CO2. Not a problem at all. But here, this paper is basically showing us that doing it on the same session is also safe and effective, and that's also my experience and the experience of many of my other colleagues. So if we then ask the question, when to start? The take-home message is, we have enough evidence now, okay, published evidence and from experience, that early intervention of scars gives us better results, okay? So the concept of let's wait until, you know, the scar remodels, that is an old-fashioned approach, because in many of these cases, the outcome with the hypertrophic or the thick scars are going to be much harder to treat. The improvement is better when we treat early on. When we are intervening earlier on, we are going to get better results, but it's also going to be easier for us. So the take-home message is, the intervention is early. When we are treating before 3 months, so relatively early on after surgery or trauma, remember, we are dealing with the proliferative phase, okay? But when we are using it after 3 months, we're dealing with the remodeling phase. And if you're using it, let's say, after 5 years, then it's pretty much a mature, established scar. And I don't have enough time now to go through all the studies. There are many published studies looking at 2 weeks versus 2 months versus 6 months. 3 weeks versus 3 months versus 6 months in the same patients in terms of intervention post-surgery. Improvement was found in all patients who were treated with the lasers, but those who were started early, so 2 or 3 weeks post-surgery, had better outcome. So basically, you treat them as soon as you see them. So for burn scars or traumatic scars, early laser intervention is important, okay? But for, if for example, we do a lot of surgery, because we have a lot of skin cancer here. We have a lot of fair skin patients with basal cell carcinomas, squamous cell carcinomas. So to do lasers on everyone is just practically not going to be possible. But there are a number of patients or some risk factors where we know that these cases are going to be high-risk cases for hypertrophic scars or keloid scars. So that is a personal history. So someone will say, I always tend to get hypertrophic or keloid scars. A very strong family history, or areas where there's delayed wound healing, infection, high tension. All of these factors are likely to then give us a hypertrophic scar, and intervening early post-surgery in those cases, we are likely to get a better outcome. So if for example, there's a post-operative wound infection, and then prolonged inflammation with erythema, and then after a few weeks, you can already see some early elevation and early thickening of the scar, intervening then with the pulse dye laser or the fractional is going to ultimately give us a better outcome than if we just wait. So again, let me just explain briefly what happens with some of the wound healings. When there is an infection post-surgery or tension, what happens is we are again changing the biochemistry of the scar. So we are going to have much higher TGF-beta 1 and much lower TGF-beta 3. And this is why we get bad scarring. So when we are in an area of tension, an infection, delayed wound healing, prolonged inflammation, the angiogenesis is going to be abnormal. We are going to have too many abnormal vessels. We're going to have a very high TGF-beta 1, prolonged phase of collagen type 1, delayed collagen conversion from type 1 to 3, and that is what gives us bad scars. So when we then intervene with lasers, we are doing the collagen conversion from type 1 to type 3, we're suppressing the TGF beta 1, and we are increasing the TGF beta 3. So now some clinical examples. I am not sure about the time, but yeah, we are okay in terms of time. So to just summarize, lasers, vascular lasers and fractional technologies work on scars by modulating their behavior and changing also at molecular level and the histology. Starting early gives us better results, and the choice of laser that we are going to use depends also on the type of scar that we are dealing with. So this was one of the unfortunate patients that I saw at the hospital, because I still work at the university hospital, a few sessions a month. This unfortunate patient had burns, but what you can see on her arm particularly, this was early on, these very hypertrophic, keloidal, intensely pruritic. They were itching her a lot. And in the hospital, from the government hospital, the first treatments were paid for by the government for the face. And she had exactly a similar thick scar in where you can see the black arrow to the one that was untreated. And she said, I know that at this stage you are not going to treat my forearm, but this scar was very, very itchy. Is there anything you can do? And I said, of course, we can use the pulse dye laser, because once again, there is a lot of evidence that pulse dye laser improves on the pruritus symptom, the itching in scars. So I use the pulse dye laser here alone, not with the intention to decrease the thickness of the scar, but really to decrease the pruritus. And to both of our surprises, this is what happened. This was early on, a few years ago, is there was not only reduction in the pruritus, but flattening of the scar. And this is a perfect example of what I explained earlier on. How did this happen? Why did her thick scar flatten after 2 sessions of the pulse dye laser alone? No steroid, nothing else. And that is because now we understand what I did was increase her TGF beta 3, decrease her TGF beta 1, increase her collagenase type 3, increase her P53, and all of these factors led to the flattening of this thick scar. And she had an advantage. The reason why she got better is because this was relatively early on. This was within the first few months of her burns. Later on, as I treated some of her other thicker scars, the improvement was slower, and that is because we waited much longer. So this was one of the first cases that really taught me that lesson, and it illustrates nicely some of the things that I explained. Now, those of you who are particularly interested in how the vascular laser or the pulse dye laser works in burn scars, this is an excellent paper. But I want to just remind you that whatever scaling you use, but we tend to use a lot the Vancouver scar scale. And the Vancouver scar scale in scar objective scar scoring assessment is the one that's commonly used worldwide. See below where I have circled that in green, itching, pruritus. Remember, this is one symptom that we as dermatologists tend to ignore. Pruritus is an important parameter when it comes to scar assessment. Many patients with burns tend to suffer from a lot of pruritus that we tend to sadly neglect and overlook. And it's important that we ask about it. But we know that pruritus can improve with the use of the pulse dye laser in scars. So we're talking about pruritus of scars. This is another paper in terms of the pulse dye laser in burn scars. And look here what it says, reduction in intense post-burn pruritus. I'll read that for you. The first and most significant improvement was that patients and their relatives commented that scar itching was reduced. So when we are using the pulse dye laser, we are also decreasing pruritus. In addition to, once again, suppressing TGF-beta1, improving TGF-beta3, and increasing collagenase type 3. This is again one of the other unfortunate patients that we saw at the university hospital, and this was just pulse dye laser alone. He was using a lot of collagen, a lot of silicone sheets, silicone gel. He was using a lot of that, but you can see the thickened areas. You can see the hypertrophy. There was itching. There was and very you can see the textural abnormality. Pulse dye laser, pulse dye laser, pulse dye laser. And look at not just the reduction in the erythema, but there is an improvement in the scar. And this is a perfect case to illustrate that the pulse dye laser, when it comes to scar, is not just reducing the redness, is not just reducing the pruritus, but it's also flattening the scars. So here, because of the elevation, once again, I want to suppress CTGF, so I do that by getting a little bit of mild purpura. So here I'm not using very low conservative settings, mid to high settings. Another example, look at this guy. This was a handsome guy going to university, very hypertrophic, very vascular, itchy scars. So they are thick, so my approach is going to be purpuric. If they were flats, I don't need purpura unless I want it faster. And then they are thick. The fractional ablative laser will going to be superior to the fractional non-ablative. Why? Because there is elevation and thickness. And I know that that is going to be better. And combining the two at the same session. So pulse dye laser first, purpura. Why purpura? Because it's thick scars. When I'm using the pulse dye laser on thick scars, when I get purpura, I get better results than non-purpura. And then followed immediately by the fractional CO2. Why fractional CO2? Because it's going to remodel the scar tissue, vaporize the abnormal tissue, and then again do the collagen switching. He's a very happy man, and I can continue to treat. Same, the other side. You can, by just looking at the scars, looking at the redness, you can see that they're very angry, very symptomatic. Again, pulse dye laser and purpura, because they are thick, fractional CO2. Okay. This was an unfortunate lady who had a melanoma excised by one of the plastic surgeons here in London. And what you see on the right-hand side is a scar that she even had Z-plasty afterwards. She had steroid injections, but it was still very thick, very itchy, and it just didn't flatten. And she was using a lot of topical treatments. So once again, there is redness, there is thickened scar. So I'm going to use the pulse dye laser, but I'm going to be using it in a purpuric setting to break the CTGF. Okay, and then I'm going to be using the fractional CO2. Why the fractional CO2 and not the fractional non-ablative? Because it's a raised scar. Elevated thick scars are going to improve better with the fractional ablative lasers compared to the non-ablative laser. And look at the results. She is very, very happy. So again, purpuric mode with a pulse dye laser, followed by fractional CO2. And I can still continue. She still has some elevation and some scar tissue that I will going to continue. But I can tell you one thing. Once again, going back to what I said very early on in my webinar. What I said is, do not look and do not measure the objective improvement in a scar and make that dictate the way you approach the scar. Any improvement in the objective appearance of the scar is going to mean a lot to the patient. This patient now had so much more self-confidence. She started working again. She lost her job. She lost her marriage. She was on antidepressants because this scar was a constant reminder of her melanoma, and people were constantly asking her about her scar. Now, with this improvement, she can easily put makeup and camouflage it, and she has much better confidence. So remember, when it comes to scars, there is also a person, a patient behind that scar that will also, you know, the patient's well-being and quality of life is important. But coming back to the approach, once again, it's a thick scar. There is vascular component. So going with a purpuric mode is going to be giving me better results than non-purpur. I know this from the evidence. And it's a thick scar, so fractional ablative laser is going to be better than non-ablative laser. Okay, so here, now, atrophic scars, dark skin. So, dark skin, now I have a choice. I want to minimize side effects. I want to minimize post-inflammatory hyperpigmentation. And it's atrophic scars. Remember, atrophic scars can nicely be improved with the non-ablative fractional lasers. So here I use the fractional non-ablative. Now, subcision I used because these are non-distensible rolling scars, or non-distensible atrophic scars. That means when I'm stretching the edges, I can still see the depression, which means that at the base of these atrophic scars, there are these fibrotic strands that are attached to the deeper fascia, and that's why by doing subcision first and cutting these strands of the scars at the hypodermis level, subcutaneous level, then I don't have that pulling effect, and he's a dark skin. I don't want to risk any post-inflammatory hyperpigmentation. These are atrophic scars, so I can perfectly use non-ablative. So subcision with fractional non-ablative laser. Again, non-distensible, subcision, fractional non-ablative filler. I published on this as well. Post-surgery. Post-surgery, you can use a pulse dye laser, you can use an ablative fractional laser, you can use a non-ablative fractional laser. Series of fractional ablative lasers post-surgery. This was an unfortunate person who had a trauma attack. So there's a scar. The scar is not really thick, okay? So I don't necessarily need purpura here, because I would only want the purpura really when I'm dealing with a thick scar. But it's red, but it's a flat scar, relatively flat. So I don't need purpura, or maybe very low purpura. And then I can combine with a fractional ablative laser in the same session. This is how she looked immediately after the combination session. You can see pulse dye laser, and then combination of pulse dye laser and fractional. And you can continue. Now I just want to briefly talk about the fractional pico. So I talked about the fractional ablative. So the choices will be predominantly in the thick scars, or when microtension relief and relaxation is required, such as the guy who couldn't open his mouth wide open, or there was an ectropion, or when you want faster results. The non-ablative fractional laser, I like to use that a lot when it comes to the flat scars or in the darker skin type patients. So the fractional pico, so just coming back, the fractional pico, again, there are a number of different companies. Okay, this is the one that I used, but just to let you know that there are different companies with different picosecond lasers and different fractional handpieces. But it's important to talk about this because it fits within the context of my webinar. When I talked about fractional technology, just to remind you, everything that I showed you so far relates to the ablative fractional and non-ablative fractional, but relates to the wavelengths that target water. So fractional CO2 targets water. If you're using a fractional erbium, targets water. And the fractional non-ablative that I showed you, the 1550, or if you're using the 1565, or if you're using the 1927, all of these non-ablative fractional lasers, they are targeting water. So this is why they're painful, because we're generating heat. The interesting part of the fractional picos is they are not targeting primarily tissue water, because look at the wavelengths that this fractional handpiece has, 532 and 1064. Now, 532 we know is not a wavelength that is absorbed by water. So our target here is not tissue water. But what is happening here is a different type of microscopic wounding or injury called the LIOBs, or light-induced optical breakdown. Depending on the wavelength and the fluence that we're using, we're either creating these bubbles, these vacuoles in the epidermis, which we call them the light-induced optical breakdown, or we're creating these cavitational effects in the dermis that we call them LICs, or laser-induced cavitation, and they are going to give us a wound healing response. So the fractional handpiece of the Pico is different, and this is the question I often get asked: what is the difference between the fractional Pico handpiece and the fractional non-ablative? The answer is the fractional non-ablative, such as 1550 nanometer, is using a wavelength that is absorbed by water, and it's using parameters that lead to increased absorption of the water, which is found in the dermis, to get to a temperature of 65, 70 degrees, giving us coagulation, and that heat is going to give us that wound healing. Again, the papers with the fractional non-ablative lasers and scars, again, relate to the heat shock proteins and the TGF-beta switching from TGF-beta 1 to TGF-beta 3. It's happening the same with the fractional non-ablative. The difference with the fractional Pico is that we are not using wavelengths and settings that are going to heat up the tissue. There is no heat involved here. It's a photoacoustic effect. But we are using the fractional Pico handpiece to create a microscopic injury that is either cavitation in the dermis or LIOBs in the epidermis. And they do three things. And I'll keep it simple. All three things start with the letter C: collagen remodeling, cell signaling, and cytokine upregulation. So LIOBs and LICs change the cytokine behavior, increase cell signaling that leads to collagen remodeling. This is just an image. It's a great paper because it's a great image. This shows immediately the LIOB with optical imaging. You can see that bubble where the green arrow is. That is the vacuole formation. That is the early LIOB. Clinically, that's what we see, that erythema. And this LIOB is going to give us that microscopic wound healing. So this was a dark-skinned patient. Now, I can use a fractional CO2. He's likely to get some post-inflammatory hyperpigmentation. I can use a fractional non-ablative, okay? But I can also use the fractional Pico. Why? Because there's almost zero risk in my experience of post-inflammatory hyperpigmentation. Very fast, painless. I don't need anesthetic cream. And I can do as many treatments as possible. And more importantly, I can delegate. So here, using the fractional Pico at settings that will going to give me the LICs, because this is predominantly a dermal problem, and then that is going to give me the 3 Cs: cytokine upregulation, cell signaling, and collagen remodeling. Remember the 3 Cs. This is a light skin type patient. Of course, I can use a fractional CO2. She doesn't want the downtime. I can use a fractional non-ablative. I can. But I can also use the fractional Pico. And I'm just sharing my experience with you and then the approach. Same here, as a patient from Sri Lanka, dark skin. By the way, just because I'm in London doesn't mean I only see skin types 1 and 2. We have a large community of higher skin types here. So here, the fractional Pico will going to be a very safe approach in him, because I can be very aggressive with my treatments, with no risk of post-inflammatory hyperpigmentation, no need for anesthesia, and then gradual improvements. Same here, patient from India, fractional Pico. So right now, I tend to use the fractional Pico a lot in the darker skin types with atrophic scars. Atrophic scars on the darker skin types. This was a light skin type patient. You can see an atrophic scar with erythema. Of course, I can use the fractional CO2, but she doesn't want the downtime. She doesn't want the crusting and the oozing. She wants to cover it with makeup. So here you can see I'm using the 1064 fractional pico handpiece. So the 1064 fractional pico is creating more of these cavitations in the dermis, and the 532 fractional pico is creating more of these LIOBs in the epidermis. So here it's a dermal problem. I go back once again. This is a dermal problem, yeah, almost like a stretch mark, for example. It's an atrophic scar. It's a dermal problem, so I need dermal wounding predominantly. It's a dermal problem, therefore I need dermal wounding, so I'm using the 1064 fractional pico handpiece because that is going to give me the dermal wounding through the creation of these LICs. And not only did she get improvement in the scar, but the erythema decreased as well. And now there are a couple of papers published on the reduction of the vascularity using the fractional pico handpiece. So it's very interesting. And I have just published also an article on the combination with another long pulse laser. I'm not going to mention it. That also improved on other components, including the vascularity. This is a hyperpigmented, slightly raised scar. I used to absolutely, hate these scars because it was very difficult to treat. I used to find them very difficult to treat. And if you use a fractional ablative, you tend to make it worse. Series of the fractional pico here using the combination of the handpieces that targets the combination of the pigment and the tissue remodeling, the dermal. I had a reduction not just in the pigment, which was very pleasing for her, but also flattening of the scar. Same here, hyperpigmented scars. So here the combination of the fractional handpiece is easy and quick and painless here, whereby I can decrease the pigment and improve on the scar tissue. Okay, so almost there. And I think I want to spend a few minutes talking about my approach to scars, because this slide is going to make things a little bit simple. So with any scar, there's a main treatment. Just like you go to a restaurant, there's a main course. Okay, you're going to have an asado, or you're going to have, I don't know, one of these Mexican nice dishes, a chili con carne, whatever. So there's the main course, but there's a pre-treatment in some cases, or there's a post-treatment, just like you'll have a starter and you'll have a dessert. So let's start with the main treatment. Now, the main treatment can be surgical revision. If you have a very small scar, a chicken pox scar, of course you can use the lasers, but you can also just do surgical revision, excise that, and then post-excision, work on the surgical scar with lasers, because it's much quicker and easier. So that's an option. So what I'm trying to say is surgery is always an option for the small scars, or where you want to do a Z-plasty. Microneedling is an option if you really can't afford a laser. That's the honest answer. I'm not being sarcastic here, but there is no heat shock proteins, there is no LIOBs, and its improvement in scar is modest. Okay, the reason I put laser in capital letter is because 9 out of 10 times, 9 out of 10 patients I see for scars, I end up using a laser. So in the vast majority of my scar patients, I end up using a laser. Now that could be the pulse dye laser, or that could be the fractional laser. So once again, that could be the fractional ablative, such as the fractional CO2, the fractional non-ablative, such as the 1550, or it could be the fractional handpiece of the pico. But in the vast majority, my main course, my main treatment is very simple, and that is a laser. Okay, so I just, like you go to some of the small restaurants, you just have a limited menu, and this is my dish of the day, and this is my dish of the day 7 days a week, laser. Now, you may have a pre-treatment. I'll give you an example. If you have a thick keloid, the main treatment is or a hypertrophic scar, the main treatment is going to be the laser. But my pre-treatment might be some steroid injections to try and soften it and try and get some reduction in the height. Or if I'm using a fractional laser for remodeling of the thickness, I'll use the pulse dye laser first to decrease the redness and also to improve on the TGF-beta 3. Or in the examples of the non-distensible, so that's when stretching on the edges of these atrophic scars, you can still see the depression, you can still see the pull. I'm going to do subcision first, okay? So in these cases, the main course is still going to be the fractional treatment, but the pre-treatment is going to be a subcision. And then sometimes there is no dessert. Sometimes you go to a restaurant, you just have the starter and the main course, and then you don't need the dessert. So there may not be necessarily a post-treatment. Or a post-treatment could be a filler. If, for example, you have very deep atrophic scars and you do subcision as the pre-treatment, you do fractional treatment as the main treatment, you still have some volume loss. So then you're going to replace the volume with a filler material. So that will going to be my post-treatment. Or where you see in the bottom, NAFR, so that's non-ablative fractional laser, fractional radio frequency, or PICO. So sometimes I'll say, okay, you have deep acne scars, I'll do the first treatments with ablative fractional laser, okay? And then this other, afterwards, maintenance treatments with the fractional PICO handpiece, or with the fractional non-ablative. Or I'll use silicone gel sheets afterwards to maintain the improvement. So for example, if it's a hypertrophic scar, hypertrophic red scar, and I'm using the pulse dye laser and the fractional, and then there's improvement, and then I'll say we'll use the silicone gel sheets for a while to maintain the improvements and reduce the reduction. There are papers that show that when you're using these topical treatments, post-treatment, you reduce and decrease the risk of recurrence. So in simple terms, for a small scar or where tension is a problem and you want to do a Z-plasty, surgical revision might be an option. And I may then afterwards do a laser treatment. If you look at the pre-treatments, if you look at the fourth treatment, so corticosteroid, vascular laser, thulium, and then the fourth one is surgery. And this is exactly what I mean. So if someone comes and says, I have a small atrophic deep scar on the forehead, I can say, well, I will be doing surgery first, then I will do the fractional treatments or the pulse dye laser treatments on the surgical scar after the sutures are removed, 3-4 treatments until it's better, because I'm going to get easier results. And then the post-treatment is going to be with the silicone gel sheets as maintenance. Or if it's on the forehead, for example, I will do botulinum toxin first as a main treatment, decrease the movement. Then I'm going to do the surgery, and then the post-treatment is going to be with a fractional non-ablative. Do you see how it works? So I have this in my mind, and then I will go through. First, I will choose what is going to be my main treatment. Almost always is going to be a laser. Do I need a pre-treatment, and do I need a post-treatment? And I hope this has made things easy for you. So finally, really, this is how I see it. Lasers and scars don't just work on the color. We are not just decreasing redness and brown pigments. We're not just improving texture, and we're not just decreasing symptoms such as pruritus, but we are also changing the histology of the scar. So this is my final slide in conclusion. I hope I managed to convince you that lasers play a very important role in scar management. Vascular and fractional lasers, so fractional means fractional pico, fractional ablative, and fractional non-ablative are a must. You cannot talk about successful scar management without having these two technologies, really, vascular and a fractional technology. And as I showed you, it's improvements in histology, function, but also symptoms. Early treatment is, we have enough evidence to support early treatment to give us better results. If you're preventing a scar, you can use a pulse dye laser, you can use an ablative fractional laser, or a non-ablative fractional laser. If you have an old, mature, established scar, fractional laser, also fractional pico, as I showed you, and you can use the pulse dye laser for redness. So, muchas gracias. Thank you all for listening, and I think, we are on time. And Pablo, I'm handing over to you, and you can then start with the questions.
Yes, thank you very much, Firas. Amazing presentation. So now we are going to go for question and answers. A todo el mundo, bueno, si quieren hacerles preguntas, yo ya tengo algunas como que fui recolectando, son las primeras que le voy a pasar y luego le paso el resto que vayan haciendo. Firas, I already have some questions, so I'm going to put the ones in the chat. Let me
Lots of questions I can see. Yeah, maybe you can help me with picking up some.
Yeah, don't worry. I'm going to put it right now.
Okay, so I mean, let me see. Let me just go through some because many of them are in Spanish, and I'm so sorry. But thank you all for those who are saying great webinar, excellent presentation. Thank you. I'm seeing a lot of messages of thank you, and I'm very appreciative of that. So one question is any point in combining pulse dye laser with the long pulse and diag in the same session? I don't see the point of the combination particularly. All of these cases I have showed you is with a pulse dye laser. There are some papers on the use of long pulse and diag in scars. These papers have shown an improvement, but what they haven't shown is the proof of the molecular behavior and the suppression of the TGF-beta 1, the increase in collagenase type 3. But you can. Now, when it comes to the Nd:YAG, there are two ways of using it. You can either use it in the sub-millisecond, so the microsecond, or use it in the millisecond with cooling. But the combination of the two, I don't see necessarily particularly superiority over that in scars, and that's also not something that's been reproduced in the literature. I'm looking through other questions, but a lot of it is in Spanish. Any experience with the fractionated Q-switch of ALMA? No, I don't. What I would say with the fractional with the fractional nano is, you know, they behave differently from the fractional picos because the type of the fractional pico is we're generating these LIOBs and these LICs, and that is what we're talking about here. I'm not sure if I'm getting some questions on my phone. Okay. Okay, so Pablo, over to you if you have any particular questions now.
Okay, yes, I'm going to put you the question is here right now. This one, I guess that was from Daniele. Are you seeing it?
No, but there is one. Okay, can I use pulse dye laser or CO2 in active acne in patients taking oral isotretinoin? The answer is yes. Now, what I would say is, first of all, yes, now we know that we can use lasers and isotretinoin. However, I am still guided by the degree of oiliness of the skin. If the skin is very, very dry and the patient is on very high dose of isotretinoin, I probably will not start, but I will start intervening when they are on 30 milligram of isotretinoin and the skin is not that incredibly dry. So with a very high dose, I probably will not going to be that aggressive, but you can combine for sure. And then I saw another question. What settings are recommended when addressing hypertrophic scars using deep fractional CO2? And then they answered the question, low density and high fluence. Yes. So in a hypertrophic thick scar, the important answer is, first of all, to know which CO2 you're using, because the parameters are going to be different from one CO2 compared to the other, because it also depends on the power of the machine, but also depends on the spot size. So the fractional CO2 that has a small spot size, smaller than 300 micron in diameter, is the one that we would want to use for deep, thick scars. And then you are going to use the high fluence that's going to get you to the base of the scar. Now, the first thing to know is, where is the histology? That's the first thing to ask. Where is the histology for your fractional CO2 in scars? Now, I use the fractional core from Candela. That one does have histology, and for the deep modes, every 10 millijoule penetrates to 100 micron depth. This is not from me. This has come from the histology studies that was done and published. So for every 10 millijoule, you're going to go 100 micron depth. So if you are measuring through an ultrasound or an OCT, if you are measuring the thickness, then you can calculate. If not, if you think you need to get down to 800 micron, then you are going to use 80 millijoule on the core deep mode, because 80 millijoule is the maximum that you can use, but that's going to give you 800 micron depth. If you want to get to 600 micron, then you're using a 60 millijoule. Now, of course, it also depends on the thickness of the skin. So basically, the thicker the scar, the higher the fluence. The maximum that you can do with the fractional, with the deep mode of the core, is the 80 millijoule. Okay, and then I will use just a 5% density. If I am using, let's say, a 50 millijoule, not a very thick scar, I sometimes, if it's a light skin type patient, can do a second pass, either with a 5% or even lower, maybe 3%, so that's giving a total of around 8% density. Because if it's a light skin type patient, the risk of post-inflammatory hyperpigmentation is less. Okay, Pablo, over to you. If there's any other question?
Yes, this Dora Martinez asks, do you use surgical type in core candela for hypertrophic scars?
So you mean classic mode to ablate the scar?
Do you have the question there? I don't know. It's
okay. So yeah. Okay. The answer. I think this is also a question that's been asked by many. Yes, you can. Yes, you can. But that depends on the size. That depends on the size of the scar and whether there is tension or not. In a very large area. So, for example, if you have a burn scar and you have a very thick hypertrophic scar covering most of the breast, then that's a very large area to ablate completely, okay? You're very likely to get the wound healing with contraction and potentially make things worse. So in scars that are relatively small and where there is not a lot of high tension, then yes, I do that. But what I have found is that when you are ablating a large area or ablating a scar where there's a lot of tension, so for example in the sternal and in the mid-chest, you are going to get the thick scar back again. So only in small scars where there is no tension, using the classic mode to ablate until you're flat, and then I'll use fractional deep mode, 50 millijoule, just one pass, okay? And then let it heal, and then once it heals, I'll use silicone gel, and then if, for example, they start to itch a little bit, or after 6 weeks or a month, it's a little bit red, then I can use low fluence pulse dye laser, or if you have an Nd:YAG with low fluence sub-milliseconds painting mode to just decrease that redness and make sure that you're not getting the recurrence of the thick scar. But you can do classic mode ablation if it's a small scar with no tension.
Okay, Firas, this is a question from Paulina. I guess it's a bit away from my knowledge, so I don't know if you see it. It's red stretch marks, non-purpuric, purpuric low fluence, risk of epidermolysis with purpuric settings. She's asking some question. I don't know if you see the...
I can't see it, but stretch marks, okay. Stretch marks, the first thing I would say is that stretch marks tend to respond slower, okay? So do not judge after 1 or 2 sessions. They take a few more sessions. In the very red stretch marks, you can still start with relatively non-purpuric. Actually, the best is to be sub-purpuric. So, just below purpura, where you're still getting that coagulation. If it's a very light pink stretch mark and it's in a light skin type patient, then getting purpura is going to give you faster results. You are going to get better results when you get a little bit of purpura. The problem is if you have a dark skin type patient, then sometimes you can get a little bit of that pigmentation. So I start first with non-purpura, and then if I'm getting improvements, then I continue with the subpurpuric. And or if I'm not getting improvement or they become very light pink, then I have to use some little bit of purpura. So generally speaking, it's subpurpuric or with mild purpura, but you have to just be careful of the pigmentation in the darker skin.
Okay. Also, there is a question from Amanda Oliveira. She's from Brazil. I saw a question, but she's using the Pico, and they are not getting the results as the one you are getting. She's saying that they usually use energy higher than the 2.1 in acne scars with 6 passes or more, and after three sessions we don't have the same results. Do you have any suggestions?
Yeah, I think, okay, look, of course, with any treatment, there are going to be non-responders. And I also have some patients who are not necessarily, happy with the improvement that they are seeing. But I always insist, when it comes to the Pico, that they will going to have a number of sessions. I always say that the first 2-3 sessions, you may then start to see some improvement. I definitely will not stop at 1 or 2. The other thing that I like to do is also the pulse stacking on the individual scars. So it's all, I guess, about, even with the fractional non-ablative, sometimes patients don't necessarily get results. I think, with acne scarring, you can do your best. I wouldn't change what they're doing. If they're doing 6 passes with high fluence over 2.1, that is the right approach. It may well be the type of scarring, because a lot of the ice pick scars, for example, will not respond that well. The box scars respond better. And then for the rolling scar components, I would suggest to try the subcision also first. Also try the stacking on the individual scars. But yeah, I also have some patients who don't respond. But this seems to be somewhat a problem in some countries like Brazil, because in Asia, the fractional Pico is the one that's used a lot in acne scars. So, sorry to hear that, but I think what they're doing is the right approach in terms of the settings.
Okay, of course there are many asking for the papers you have presented.
Is there any particular paper that, I think the one on, the one on the laser consensus is very important. I think the one on the laser consensus is the one that I would send, and I will send some others to you.
Okay, perfect.
I think yeah?
No, continue.
We're running. It's 20 past 4 now. We've done almost an hour and a half.
All right, here's one of the last questions. I'd like to know about your experience with LLLT, I don't know what's that, in wound healing by burns.
No, not, when it comes to that mode of treatment, it's the plastic surgery department that deals with it. So I don't. There's a question from Alvaro. I can't ignore that. Hi, Alvaro. Just a few words on 532 versus 595 for telangiectasia and rosacea. Okay. Of course, Alvaro is very experienced. So I'll just explain. So the 532, as you know, is the KTP, and the 595 is the pulse dye laser. When it comes to telangiectasias and rosacea, now, if you are experienced using the 532, you can also get nice results with that. There are some differences. The 595, for example, the one I use, which is the V-beam from Candela, has the linear spot size, the 3 by 10 millimeter spot size, that I really, really like for the individual telangiectasias. It almost always works 100% of the time. 10 millisecond or 20 millisecond, using around 12 joule, between 11.5 to 12.5 joules, 1 or 2 passes, often very, very good results. When it comes to rosacea, I think the new pulse dye laser that I'm using, where I have the 15 millimeter spot, is the largest spot size that you can have in a vascular laser. So what I'm doing is the layering technique. We're starting with a 15 millimeter, so that is really deep. and then moving on with the second pass to a 9mm spot. You can also use a 10mm spot, which is a little bit more superficial. So the idea is that it's a layering technique. First, I'm targeting the deeper vessels, then I'm targeting the more superficial vessels, and then I use the 3x10mm to close down the individual telangiectasias. It works perfectly well for me, and you have seen my images. That I like very much. Now, the KTP would also work. The problem is if you have very deep rosacea, you're somewhat limited with the depth. And also in a higher skin type, the 532 is going to be highly absorbed by melanin. So you need to be a little bit careful in the darker skin types, because the KTP could potentially overheat the surface of the skin, whereas it's a bit better with the 595. So when it comes to telangiectasias and rosacea, I prefer the 595 because it has the 3x10mm elliptical spot size. I now have the 15mm spot to start deep, and then the second pass is more superficial, and then it's safer when it comes to the higher skin types compared to the KTP. And then there's another question: does the spot size matter when addressing hypertrophic scars with PBL? Bigger spot size better? Yes. Preferably start with a large spot size, because you are going to have less scattering and better depth of penetration. So a 10mm spot is perfect. I wouldn't use a 5mm spot. The problem with the 5mm spot, for example, is that you're going to use a very high fluence to get your endpoints, and almost certainly you're going to get some superficial changes or even epidermolysis and blistering. So in that case, if you don't get your response with a 10mm spot, then sometimes you're going to have to shift to the 7mm. But yes, to answer your question, a larger spot size is better. Actually, whenever we're dealing with scars, with acne, with rosacea, we're now moving over to the large spot size. The large spot size is definitely going to give us better results. I have also recently published a paper on resistant port wine stains with lasers, and my experience on successfully treating them with a 15mm spot, because you get better results because you're penetrating deeper. Okay, so lots of people are saying thank you very much. I will type in here, thank you all very much for listening. Muchas gracias for everyone.
Firas, as always, thank you really very much for your time and to give you your experience. I hope to have you again here in Argentina. Now, of course, next year. And okay, I don't know if there is more question, and I guess to the next time.
Thank you, muchas gracias. And remember, next time I come to Argentina, we have asado together, okay?
Yeah, of course, and wine.
Thank you all.
Para todo el mundo, también les recuerdo que a continuación, 13 horas y 16 horas, tenemos otras dos charlas. Una con un perfil más con tips comerciales sobre cómo ofrecer la tecnología en este contexto, cómo ofrecer tratamientos de láser, comunicar tratamientos de láser para los pacientes, para todo el mundo. Y a las 4 de la tarde, ya algo más con perfil clínico, va a estar Fernanda con la doctora Jaime hablando de tratamientos vasculares. La doctora Jaime tiene muchísimo conocimiento, mucha experiencia también en malformaciones y patologías vasculares complejas, así que espero que lo puedan disfrutar. Firas, thank you very much again, y muchísimas gracias a todos.
Okay, thank you very much, and we see you again.